So few questions. I don't know how many will be pertaining to TAVR mitral clip for the board, but let's see. So the following are the true statement regarding core valve trials. 1 year mortality is lower than SAVR. Then CVA incidence is higher, everything except. Then vascular complication is higher. True, right? Residual PR is lower than SAVR, and moderate, this is a paravalvular leak, okay, aortic regurgitation. Does not correlate 1 year. Of course, it correlates with 1 year mortality. Everything except which one? Taking everything into account, I think probably B, right? It is not higher between the two valves. Between the two valves, is there any trial that has shown which valve is better for CVA? That two trials, one showed each. One said sapien is lower and the other one said core valve is lower. But what is the incidence of CVA if they ask you a number right now? Used to be about 3.5 initially when it started, but they are about 2% or so, okay? Correct answer is B. Following are the true statement regarding core valve pivotal trial. High risk. So you have to know how the trials happened. First was extreme risk, right? Then high risk, then intermediate risk, then the low risk. So they just moved down. So similar incidence of 1 year mortality, TAVR versus SAVR. True, right? Incidence of life-threatening bleed with TAVR versus SAVR. CVA was numerically lower with TAVR versus SAVR. No, that is wrong. Similar incidence of vascular complication with TAVR versus SAVR, everything. All major outcome is similar with TAVR and SAVR. That is true except C. CVA was numerically lower. No. That's not the true answer, okay? What is the incidence of pacemaker? This definitely they'll ask. And where is the pacemaker higher? Who is risk for pacemaker? Who is at risk for pacemaker? Underlying right bundle. Yeah, very important. So they can show you an EKG, then they will say, okay, what you have to do, how you avoid it. How do you avoid it? What is the incidence? I don't know. In this way, I don't know, maybe C, but it's about 10% now, 5 to 10%. Let's see what the answer they've given. That was very early part. Now it's gone to 5 to 10%. Okay. So what I'm saying is how do you avoid? They may ask you the steps. Anybody knows? One, you know what are the predictors, right? Predictors, and then yeah, cusp overlap is very important to avoid that, and the implant depth. And now they have newer things going on to understand the septal thickness, where the septal, all these the measurements they have to do. I don't know if they can go that deep, but just be ready to understand. They may show you some CT scans, okay? You know how to answer. They'll show you some CT scan, heavy calcium, and then which valve would you want to pick for what? Do you know how anybody knows how you pick the valve depending on what the CT scan findings are? No, that is for the size. Calcium, no calcium. If it's heavily calcified valve, that's the time most people go to the core valve rather than sapien, because the risk of rupture, because it's balloon expandable, and when you expand, there's a risk of rupture. That is the key, okay? Then depending on the perimeter, height, coronary height, and the leaflet length, which valve you want is a total different. But the biggest difference is between the two, if they ask. which valve you want to pick for who. Following are the true statement regarding core valve trials. 1 year mortality lower than TAVR, CVA incidence is higher, right? True. Vascular complication, oh my God, it's all wrong. This is the same question, no? Okay, following are the true statement regarding SAPIEN versus core valve trial are in extreme risk group. Is 1 year mortality? What is a 1 year mortality? What is the procedural mortality for these valves now? About a 1%. CVA, like I mentioned, 2%. And then vascular complication, vascular bleeding, about, no. You have no more than about 3% or so. Everything has gone low. So the trial, whatever they showed, you have to remember, these are like 8-year-old, 10-year-old trials. So what is the true statement regarding SAPIEN versus core valve is that 1 year mortality 15 to 20%. 1 year mortality. I think in the trial they definitely showed the mortality was close to 30%, right? So then I think the right answer could be C or E. E, I think. E. Because these are all the older valves. Okay, very important. How do you do? What is the definition of a TAVR valve degeneration? And how do you make the diagnosis? If the patient comes back to you few months, there is where you do echocardiogram. So when the patient is going home, what is the base once you place the valve, what is the gradient that you expect? So at the baseline you have to be less than 10, okay, less than 10. So what they say is when they're coming back, so gradient, if you have a residue, so you have a gradient, I'm just telling you, is 12, and when they come back, if you have a gradient change of more than 10 or overall more than 20 compared to the baseline they left, that is when you say, okay, the patient has a TAVR valve degeneration. You have to know the exact number. And to confirm, one, you do echocardiogram. The other way to confirm is to repeat the CT scan. Yeah, you have to do the CT scan. And what's the reason for degeneration? Is thrombus. So thrombosis. So in that situation, you have to put them back on anticoagulation, ideally Coumadin, but most people don't like to take Coumadin or any kind of anticoagulation, and then repeat it in 6 to 8 weeks, okay, to see if anything has changed. But that number, they will ask you. There's a clear definition of this TAVR valve degeneration. But that is acute degeneration. What's the incidence at 5 years? Because why this is important, patients will ask you, why should I go, 70-year-old healthy guy, low risk, will ask, okay, what's going to happen? Because the surgeons will tell, they have a lot of data for 30 years and we cannot beat that. So if you want to convince the patient that you have to go for a TAVR, and what has that study shown? At 5 years has been less than 5%. So we have good data for that, okay? True statement regarding BAV. This thing can come, BAV in extreme risk AS patient. One-year mortality is lower with BAV, CVA incidence higher. Is the CVA incidence any higher? Compared to TAVR? No. So BAV is usually offered to what? Extreme risk and inoperable cases, right? So Just try to understand what they're trying to get at. That for not say mortality is okay, but at 1 year they haven't survived. That is inoperable cases. That is why the trial showed is that you do BAV for futile patient, or it is not even worth it because they did not even survive 1 year. So I think the answer is C. Other one is wrong. CV incidence is not higher with BAV. Okay. The reason with the valve it's higher is it's a bigger, bulkier device, and when you navigate through the aorta compared to the balloon, it goes flexes and goes easy through the arch compared to the valve. True statement regarding balloon post dilation post TAVR, because there are a lot of concerns that should you post dilate a TAVR valve or no, right? So what is the true incidence? How often you have to post dilate, and when do you have to post dilate, right? Is it okay to post dilate? Does post dilate give rise to any issue with the TAVR valve? Incidence of a post dilation is about 10 to 15%. Lot of people believe not to post dilate or pre-dilate. Okay, just go place the valve and come, and only if there is a paravalvular leak you post dilate. Or if you're suspecting that there's a lot of calcium and subsequently there will be a leak, that's the only time you want to pre-dilate also. So you try to avoid multiple dilation pre and post. So it is very low, about 15% or so. So of that, so you can pick 15 to 25%. Everything except what? No, that's why you do. Except valve degeneration, there was no correlation post TAVR balloon inflation has resulted in valve degeneration. Okay, so based on the valve size, annular size, you pick the balloon size. You don't want to post dilate it to such a large size that now you develop central AI. Okay, so that is important that you pick, but otherwise there's no incidence of valve degeneration in these cases. Stroke after TAVR. Is it after 24 hours? See, what people believed is that multiple exchanges can give rise to stroke. So post dilation, people wanted to avoid to see that if there will be lower incidence of stroke. When is most of the stroke happen when? First 24 hours. Okay. Now, delayed stroke are likely due to AFib. First 30 days, patient went home and then had a stroke at home, likely due to AFib. So that is why I think we are making a point that post dilation has not shown to increase the stroke. Okay. Is it 4 to 10% now? No. Yeah, it's not. So C. Prosthetic valve failure, right, is high risk and intermediate risk, not for low risk. Approval. So TAVR approved in up to what? Severe aortic symptomatic patient? Low risk. Symptomatic moderate aortic stenosis in extreme risk patient? Yes. Symptomatic stenosis in intermediate risk patient? Yes, everybody. Right? So of the three, I think remove the moderate, right? Symptomatic moderate aortic stenosis, wait till it's severe. Which of the following transcatheter valve is approved in the United States? Oh. Is it Intrepid TAVR? Yeah. Mitral, yeah. Lotus, removed. Yeah. What happened to the slides? Okay, good. What are the possible access approaches to TAVR? Oh, D, my God. 92-year-old male with COPD, PVD, prior cabbage, symptomatic severe aortic stenosis. Which of the following is not a standard part of pre-TAVR evaluation? C, right? During TAVR, after the valve is deployed, a patient remains persistently hypotensive despite resuscitation. Which of the following is least likely cause of persistent hypotension? Yeah, B. Usually if it's acute stroke, they don't wake up, right? Nothing to do with the hypotension. I hope that's B. Yeah, good. These are simple things. Most likely cause of out of hospital sudden death in a patient discharge. What is the likely cause? Yeah, complete heart block. You have had so many cases. So if you want to discharge them home, you just have to put them on a monitor. Yeah. Which of the following is not a predictor of mortality after TAVR? D. Right? Everything else is. Then what is this? 85-year-old female, 24 hours after successful TAVR, developed acute chest pain with ST depression. Most likely cause is what? D. Acute, delayed coronary obstruction, occlusion. According to the partner and Certavi trial, randomizing TAVR versus TAVR in the intermediate risk, right? Which of the following findings are false? Transfemoral TAVR is superior to SAVR in the primary outcome in partner trial. Yes. TAVR is equivalent to SAVR in primary outcome in Certavi trial. Yes. TAVR has more paravalvular leak. Yes. Oh, no. Partner and Certavi, were they a comparison trial? No. Partner was Sapien, Certavi was yeah. So they were never a comparison trial. Which of the following is not a risk factor in heart block? This following is a known predictor for parallel leak in TAVR. Which one? B. No. B is. Yeah. Except high. No, B. No, B is. Undersized. A. Valve oversized. Predictor. Except. Yeah. So just some for the clip, before clip was approved, which was a trial that led to clip approval, which they'll ask you, is average 2. Okay. So randomization was what? 2 to 1. Okay. Control over the device, which was MitraClip versus to a control group. Follow-up up to 5 years came out in. So a significant MR 3 to 4 plus. And then it was published. So comparison was control versus device, essentially saying it is a safe device. Okay, not very effective, but very safe device, H2H repair. So that led to the approval, and it was published in New England Journal. So this is what it said. But what was the approval first for? Degenerative mitral valve. that percutaneous repair is less effective. You saw that compared to surgery, it is less effective in reducing mitral regurgitation, but was safe because it's a venous procedure. Death was very low, nothing much you expected. And what did you also find? This is the one is important. At 12 months, if you see here, close to 18% had MR 4 to 3 plus. Okay, but then if they continued on medical therapy, NYHA class was almost 1. So even if you left them with moderate MR with one clip, just with medical therapy, they did well. That is why it was means compared to surgery. You see, in surgery, they are very effective. But what we are trying to say is you don't have to have surgical result. Even if you have mild to moderate MR, if you have medical therapy subsequently, they did well in this group. And the same, whoever required any surgery or clip after 6 months, freedom from death and reoperation was equal in both. So following are the true statement regarding the mitral clip in average trial. Mitral clip is safer. Yes. Mitral clip is inferior. Yes. Majority of the clip patient has severe. It's not severe residual. Mild to moderate. Okay, you saw the number there, 18%. Mitral clip was well tolerated. That's good, right? So what's the answer? Good. Then, what was the incidence of residual moderate to severe MR in mitral clip? I showed you the number there, 18%, 10 to 20. Yeah. Following are the primary effectiveness endpoint at 1 year of COAPT trial. What was the primary endpoint? Yeah, rehospitalization. Rehospitalization. Remember that. That was the thing. And of course, they showed that there was a mortality benefit, but endpoint was rehospitalization, primary endpoint for the FMR, which led to this. I'm not sure whether we'll make it because, it's just within 2 years or so for the thing. Any other questions? I don't know whether they'll ask you technical questions. They may ask you echo-related questions. Okay, show some echo to understand what it is, whether you can see a clip, not see a clip, what the valve looks like on an echo. You guys have to know that, what the TAVR valve look like in echo or so. That's it, I guess, related to the TAVR. And then some of the trials, of course, we'll go over later on. Know all the partner trials, the core valve trials, SARTAVI trial, the Everest I showed you, COAPT, okay? And the approval for COAPT has happened for patients who are, so in the heart team discussion, it's very important that patients have to be seen by a heart failure specialist. Now, for the TAVR, heart team is what? Surgeon, interventionalist. That's it. For the clip, you don't, if it is degeneration, okay, these are things they may ask you. If it's a degenerative primary MR, you need a surgeon to say that patient is prohibitive risk, not low, high risk, or prohibitive risk. If it is a FMR, then you need a heart failure specialist. That patient is on medical therapy for at least 4 weeks and on medical therapy, GDMT, okay, which could be an ACE inhibitor. There has to be on diuretic and all the others plus minus, and then after that they still are symptomatic, and has to have moderate MR, moderate to severe. Those are the patients that will get into the trial.